When you teach patients about that, the side effects are going to be maybe somewhat different because it's more of a regional treatment with less systemic toxicities. So it's teaching patients about the drugs, the side effects, the actual procedure itself.
You're listening to the Oncology Nursing Podcast, where ONS Voices talk cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from bench to bedside and everywhere in between. Welcome to the Oncology Nursing Podcast. Hello and welcome to the Oncology Nursing Podcast. I'm your host, Jaime Weimer, Manager of Oncology Nursing Practice at ONS. And today we're talking with Lisa Hartkopf-Smith, Advanced Practice Nurse at OhioHealth Center in Columbus, Ohio, and ProMedica Cancer Institute in Toledo, Ohio, about the oncology nurse's role in intra-arterial chemotherapy administration. As a reminder, you can earn free NCPD contact hours after listening to this episode and completing the evaluation that we've linked in the episode notes. Thanks so much for joining us today, Lisa. It's great to have you.
Great. Thank you. Nice to be halved.
So to set the stage for today's conversation, let's just start with sort of a broad overview of how intra-arterial chemotherapy administration has sort of evolved throughout the history of cancer care.
Great way to start the conversation. Intra-arterial chemotherapy has actually been in existence over 70 plus years. It's been around for a long time. There are case reports in the literature as early as 1950 of intra-arterial chemotherapy, one specifically being giving nitrogen mustard, of all things, intra-arterially through a catheter for the treatment of Hodgkin's lymphoma. There's other case reports in the 1950s through 70s that discuss intra-arterial chemotherapy for all kinds of cancers, including melanoma, hepatocellular carcinoma, pancreatic cancer, lung cancer, uterine cancer, cervical, prostate, colorectal, osteosarcoma, and breast cancer. Just personally, during the 1980s, when I was a new nurse, I had a brand new grad. I was involved with taking care of patients getting intra-arterial chemotherapy. What they would do, this was in the case of sarcomas, the radiologist would put an art line in and thread it through the femoral artery and thread it to the tumor, whether it's an upper extremity or lower extremity sarcoma. And we would get these patients on the floor and they would be on bed rest for 2 to 4 days with that line in. And we had to manage that and make sure it didn't come out and make sure the patient was comfortable and didn't have hemorrhage.
Oh, wow. Just managing an art line alone is sometimes stressful enough for me. So when you add chemotherapy into the mix, it just seems, especially for a new grad, it seems like a lot. So that's amazing. So it's obviously been around for a long time. But what are some of the key advancements and their implications for oncology nurses in terms of how intra-arterial chemotherapy has sort of evolved?
Well, one of the key advances was during the 1980s, a 5-FU prodrug called fluoxuridine or FUDR. That was approved by the FDA for intra-arterial use only. That allowed the drug 5-FU, which it's, like I said, 5-FUDR is the prodrug for 5-FU. It allowed it to be in much, much higher concentrations. So that was a key thing along the way. Another key thing that happened was that implanted pumps were developed. So in the 80s, there was infusate pumps and Medtronic pumps, which are those small hockey puck size pumps that are placed on the lower ribs and abdomen with a catheter threaded into the the hepatic artery. And they allow the FUDR chemotherapy to be pumped at about 2 cc's a day, depending on the pump itself. That was a big movement forward because we had this specific drug to be given intra-arterial that was good for liver mets. The other thing that's happened along the way is hepatic chemoembolization was developed, about 2010, 2020. And this is not administration with nursing wise, but administration in interventional radiology or in the operating room where an art line is temporarily placed in the hepatic artery and chemotherapy is given, and then an embolizing substance to clot off the blood, and then that line is discontinued. That was big. And then along with the treatment using intra-arterial chemotherapy for retinoblastoma. So in the past, the most common treatment for retinoblastoma in children was to remove the eye. But then with intra-arterial chemotherapy of retinoblastoma, particularly melphalan, art line is threaded up all the way into the ophthalmic artery, into the back of the eye, and chemotherapy is given. And that's really has a great cure rate and also allows the child to keep their eye. So those are some of the major advances. Some of the things we've learned along the way is that when we do give intra-arterial chemotherapy, it's a very regional type of therapy. So we can give high doses directly to the tumor. But then there is the risk of systemic disease. So that's what we learned. We were giving all this chemo for liver mets from colon cancer, but then the patient developed lung mets. We've learned that patients need, in many cases, systemic disease and regional intra-arterial disease chemotherapy. Systemic chemotherapy and regional chemotherapy.
That's really amazing, especially how you explained how it's now being used in retinoblastoma and just the advances that's now helping to preserve eyesight. Like it is amazing, but also just so fascinating how it is, given and targeted so directly. So thank you for sharing that sort of history and context of, where it started and where it is now. Let's talk a little bit more about some of the common indications that we typically see intra-arterial chemotherapy used and how that administration route is particularly effective for those certain types of tumors.
So as I mentioned just a minute ago, retinoblastoma is a common indication at this point in time for intra-arterial chemotherapy and has very good success rates. Intra-arterial chemotherapy is also used in liver cancers, whether it's an unresectable liver metastases from adenocarcinoma of the colon, or it's unresectable intrahepatic cholangiocarcinoma, as in another example where it's used. And it can also be used in hepatocellular or HCC carcinoma.
And as you mentioned, some of the decision making when it's being administered is likely asking that question of, is this a localized tumor? Is this something that, would benefit from this local regional type of therapy? Or is that risk for distant mets, something that would maybe not make this the best or the only treatment that could be used for that patient? So I think that's a really important consideration that you brought up.
Exactly. And although those questions continue to be, or the best way to go about it, continue to be asked and investigated. There's currently over 70 clinical trials in the U.S. involving intra-arterial chemotherapy to try to answer those questions, the best way to do it, when we use systemic, when we don't, what drugs to use, et cetera.
That's wonderful. So for those nurses, those oncology nurses who are caring for patients who have been ordered to receive intra-arterial chemotherapy, what are some key aspects that they should be considering maybe before they're getting that treatment? Are there some sort of pre-assessment considerations that they should keep in mind?
Yeah, some of it's similar, but it also varies according to whether it's, somebody that's going to get it through an implanted pump or whether it's somebody that's going to go have it done in interventional radiology or the operating room. Some of the things like pre-treatment, things that the nurse has to look for in any of those are labs, and particularly clotting times, to make sure that a PT and an INR and a platelet count was drawn, because this patient is going to have a catheter in their artery and frequently will have heparin. So you need to make sure you know what that is. Also, checking out pretreatment labs like a CBC and a DIF and a CMP. The CMP, particularly because of renal function, in case there's dye that's going to be involved, because often with any of these treatments, the physician, the radiologist, or the surgeon will inject dye to see where the artery is and what the blood flow is. So checking renal function before that patient gets the dye injected, and checking renal function because sometimes drugs like cisplatin are used for these types of treatments. So those and patient knowledge base, knowledge of the chemotherapy and the side effects of the chemotherapy. When you teach patients about that, the side effects are going to be somewhat, or maybe somewhat different, because it's more of a regional treatment with less systemic toxicities. But then you're also dumping treatment right on an organ. And sometimes, for example, if it's the liver, people can respond with a type of chemical hepatitis. So it's teaching patients about the drugs, the side effects, the actual procedure itself.
I think that's a really important point that you brought up about the patient education. And, maybe it could be that your patient has already received some type of systemic treatment. And so I think emphasizing how this is different and unique is really important. And even if they've not, maybe this is their first treatment that they're receiving. I think, making sure that they are going into it with the right expectations of maybe they're assuming it's like systemic chemotherapy and they're envisioning lots of toxicities and side effects that might not be the reality because their treatment is more regional or local. And so I think that's a great point to emphasize of just level setting with patients, understanding what information they have and their understanding of the treatment they're about to undergo and helping to clarify those expectations so that the patient is prepared for what to expect.
Exactly. Like for example, when you're pulling your drug information, your patient drug information sheets, it may not be appropriate to give the adriamycin teaching sheet from Oncolink or ChemoCare or ONS because that's generally the side effects of systemic treatment. Whereas if it's going to be given intra-arterially, they are probably not going to have hair loss and mouth sores, and their blood counts may not be affected.
That's a wonderful point to make out, and it truly applies to any of the more unique administration routes that we use, because you're right, those sheets are typically, because that's maybe the more predominant route, those are usually written with the expectation that it's that systemic intravenous administration. So I think that's a great point. When I used to work in the GYN population, we would give intraperitoneal chemotherapy. And so I'd have to always kind of create that distinction of this is the drug you're getting, but some of these side effects we don't expect to result in the same way because the absorption and the administration is going to be very different for you. So that's an excellent point to pull out for sure. So now let's talk through the administration process. As you mentioned, it's really only used for select cancer types, not as broadly used as just general systemic administration. And so I think many nurses are not familiar with this type of therapy. So if you could walk us through just what that administration process is like, give us a high level overview, and just kind of, help us understand what that nurse's role is throughout that administration.
In some cases, the nurse, may be actually administering the medication, and in other cases, they're not going to be actually administering it. So if you have the situation where that intra-arterial procedure is done like within the operating room or interventional radiology, then typically the radiologist or another physician will be administering it. But the RN may be in the room. It's often not a chemotherapy qualified RN. It's often the interventional radiology RN. So this is really a group effort between oncology nurses and those interventional radiology nurses and operating room nurses. But in that case, as far as administration, again, it will probably be the physician, but where the nurse can play the role is with all those steps of verification. So the dual verification process for chemotherapy needs to not just apply when you're giving it IV in an infusion center or inpatient, but it needs to happen in those off sites like interventional radiology in the operating room. So the nurse in the suite can work and be part of that dual verification process, comparing the orders with the drug and the patient identifiers. The nurse in that type of situation, interventional radiology or operating room, can help ensure that safe handling occurs because those employees and physicians may not be as familiar with it. So making sure that you have the PPE, the gowns, the gloves, goggles, and the correct ways to dispose of it in those suites. Some locations will use their closed system transfer devices on the syringes when they give it in those areas, and other places do not because they have difficulty with the connections that they have. But just even investigating that, ahead of time to see if it works, if it doesn't work, and what those areas can do to protect themselves from the medications. So that would be administration or helping with administration in a IR or an OR suite. As far as administering it itself, with the implanted pumps, that's a lot of education for nurses to learn how to do that. And many nurses in infusion centers and offices learn how to work with the pumps. And I'm talking about the intra-arterial pumps, such as the Intera pumps, which are the ones I mentioned previously that look like a hockey puck and that are put in OR or interventional radiology. So it's all underneath the skin, and it's very specific how you give the chemotherapy into that pump. That the nurse has to know what the brand of the pump is and what the details of using that pump are. They typically have very brand specific installation kits that have like a straight Huber needle or non-coring needle and syringes and stopcocks with that. And so the nurse would be involved in administering the chemotherapy with a syringe attached to this long non-coring needle. Initially, it's an empty syringe. You find placement to enter the septum that will go to this reservoir in the pump, and anything in their pump will back up into the syringe. And then once it stops backing up, you change and put the syringe of chemotherapy onto that and push every usually 3 to 5 milliliters and stop. And to check placement, you just wait for that plunger to back up from the pressure in the pump. And so that's typically done, and you use a fill for 2 weeks, and it will pump for 2 weeks, 2 cc's at a time. And then it's typically FUDR 2 weeks on, and then the 2 weeks off, you have to do the same process, but it's filled with heparinized saline.
That's interesting. So yeah, that it had a lot of questions swirling around as I was listening, and a lot of them you just answered. So it sounds like when we're working with that implanted pump, that when the nurse is administering it, technically they're filling it back up. They're filling the pump back up so that it can then continuously infuse over that next 2-week duration.
Exactly. It's 2 weeks of chemo, 2 weeks of heparinized saline.
And is there a common number of cycles that's done, or is it just dependent on response?
It's dependent upon response, because typically these patients, it's not curative, and it's for people with colorectal liver mets that are unresectable. So just, in other situations where you treat by scans and side effects, you continue to treat and, until the patient has too many toxicities. And in the case of hepatic artery chemo, it may be that their liver function tests get really high, or you treat by, toxicity and also by scan. Are they progressing, or are they having a good response to it?
And for the former way that you described it, when it's given either in interventional radiology or in the OR directly, is that typically given cyclical as well, or is that a different indication where it's maybe just a one-time administration?
That's a great question. For hepatic chemoembolizations, those are usually, they're not cyclical. It's usually depending on the situation, it may be once, it may be twice, it may be 3 times. So it's not, every 2 weeks until you progress, or every 2 weeks times 6 times. It's typically a set number, and it's very low number, 1 to 3.
And I really appreciated your emphasis when talking about how if the nurse is functioning more in that supportive role, if it is given in an interventional radiology or OR area where the nurse is not directly administering or filling that pump as it's done in the outpatient, but they are more as just, I think, a great role for oncology nurses to serve is to, ensure that the same safeguards and verification processes and PPE are being used consistently, no matter where this drug is given, not only to protect the patient, but most importantly, or equally importantly, I guess, is to protect the healthcare providers. And so I think you really did a great job of calling that out, because I agree. I think sometimes in these areas that maybe don't give it all the time, or it feels a little bit less routine for them, they may not be aware, or they may not value some of those steps as much as we know as oncology nurses that it really just has to be a routine process. So I think that's a great call out of how oncology nurses can serve as that educator to make sure that our colleagues know the same information we do and are practicing in the same safe way to protect themselves.
Yeah, it's a village.
Can you expand a little bit about the catheter placement, the precision of where the catheter is placed, whether it's given in the interventional or OR space, or if it's actually part of that implanted port?
It's important to know where the tip of the catheter is located and that it hasn't moved. And would be more for not the procedures in the suites like IR or OR, but if you have an implanted pump, or if there's an external catheter or pump, because initially when the catheters are put in the pump or any of the external catheters, the tip placement has to be noted when it's placed. But with time, just as it would with a venous port, the catheter can move out of place. So even with the implanted pumps I was mentioning before, those catheters can move. And so we don't routinely check placement of the tip. What can happen is if the tip moves into another place, the patient will have those high doses of chemotherapy going systemic and will experience more side effects.
So I know we've touched on this a little bit, but let's just focus in one more time on some of the adverse reactions we see, some of the toxicities that are possible when giving intra-arterial chemotherapy? And are there any specific nursing or non-nursing strategies that have to be used to manage those?
Some part of the adverse reactions could be related to the catheter or the pump itself. And then some of the adverse reactions are related to the drug itself. Starting with the adverse possibilities for the catheter or the pump. If it's a catheter in an artery, there's always the risk for a thrombus because it's in the artery. So if it's a temporary catheter infusing, that patient could develop a clot at that site and block circulation to the area below. So for example, if it was chemotherapy for a sarcoma, which they still do sometimes intraarterially, you would need to check for circulation in that affected limb, like below the area of the catheter insertion. So you'd worry about thrombus. I have actually not been involved with any of the brain tumor intraarterial infusions, but those are threaded up into the brain, and related to thrombus, there is a risk of stroke. So it would be assessing for that. So other things that can happen with catheters and pumps, whether they're temporary or permanent, is always the risk for hemorrhage because it's in an artery. So if something breaks or some tubing becomes disconnected, then the patient could hemorrhage. So it's important that everything is always lured locked, connections taped, and that it's being checked frequently to make sure that everything is tight and secure so that there's not that risk for hemorrhage from a catheter, an IV tubing, or a needle becoming disconnected. There may be some discomfort at the site of the catheter insertion or of where, if it's an implanted pump, that location. In the case of the implanted pump, sometimes patients will develop seromas around the pump, so they get swollen and tender. That's a potential problem. Other things to assess is maybe the pump is not working correctly. And I'm talking again, implanted pumps. Doesn't happen that often, but one of the reasons you would know that it was not working properly, as I had mentioned, every time before you fill a pump with saline or chemotherapy, you're attaching an empty syringe through that non-coring needle and letting anything in the pump back up into that syringe. So when you get the amount in the syringe, what you do is divide that by the number of days it's infusing to see what the rate of infusion was. So if it's infusing not enough or too much, you'll be able to figure that out, and there may be something wrong with the pump. Or it could actually, if it's infusing too rapidly, it could be because of the patient has a fever, the patient was on an airplane, or a change in altitude can affect some of those implanted pumps. So that's the device itself, some of the things to check. As far as the drug adverse reactions, again, it's going to vary from what that drug would be if you were giving it IV, because the dose is typically higher when it's given intra-arterially. And as I mentioned before, you typically don't get the systemic side effects. If it's an infusion, some things to assess for, if it's a hepatic artery infusion, whether it's hepatic chemoembolization or TACE, or whether it's another type of the implanted pump that's going to the hepatic artery, it can be very hard on the liver as far as you're dumping all those chemicals on the liver, and patients can get a chemical hepatitis. And that can happen sometimes 1, 2, 3 weeks after they've received the chemotherapy. So it's important to monitor those liver function tests and monitor them for signs and symptoms of hepatitis. With the hepatic artery infusions too, regardless of the route of administration, patients can have nausea from it. So it's important to make sure they have scheduled antiemetics, at least for the first couple of days. They may, if it's a nephrotoxic agent that's been given intraarterially, there may be hydration ordered, IV hydration or PO hydration, and it's important to check your I's and O's and make sure that that's happened. Or other very site-specific side effects, again, if it's hepatic, pain, nausea, elevated liver function tests, those are typically the most common things.
Thank you for that. I mean, I think, as you've mentioned, this is a unique administration route, and it can be given for a lot of very different types of diagnoses. And so, as you've mentioned, they kind of have to take into account not only what drug is being used, but how it's being administered into what location. And I think that is a good frame of reference as the nurse is trying to assess kind of what to watch for and be mindful of. Those are some of those key factors that have to be incorporated into that sort of clinical critical thinking.
Some of those side effects in the Oncology Nursing Society, the chemotherapy and immunotherapy guidelines and recommendations for practice in Chapter 11 is the intra-arterial section, and it outlines a lot of the information we've covered, but also some of the side effects for those specific drugs when they're given intra-arterially.
Wonderful. So what would you say when you are working with patients who are receiving this therapy? What are some of the top things that you try to emphasize and educate them about as they're experiencing this treatment?
A lot of it has to do with side effect management. And again, depending on where that chemotherapy is going, but nausea management, pain management are two things. If it's a device that's implanted, it's the care of that device, the things they can do, the things they can't do. If it's an implantable pump, let us know if you're on an airplane, let us know if you've had a fever, those types of things.
Yeah, that airplane one is very unique. Certainly not one that applies to, I don't know that it applies to any other treatment route, at least not the standard ones. So that's very interesting. I appreciate you bringing that one up. Well, Lisa, thank you so much for all of the wonderful information you've shared today. I have certainly learned a lot just because as in my personal practice, had never really experienced administering or even really working with the diagnoses that use this type of treatment route. So I definitely learned a lot. I'm sure our listeners have as well. As we wrap up our episode today, we always like to run through a few quick fire questions just to summarize some of the talking points that we covered. So to start that off, what are some common misconceptions about intra-arterial chemotherapy administration?
Possibly that there's only one or two ways to do it, and there are multiple routes, catheters, techniques, and diseases that it's used for.
What's something about this topic that's not often discussed, but you wish people knew more about?
I honestly think this entire topic is something that's not discussed much, and I wish people knew more about it. I also wish people knew more about one of the areas of this topic are hepatic chemoembolizations, also called TACE. There are a lot of patients out there that are getting this in different locations, different hospitals, parts of the country. But because we typically are working in infusion centers or inpatient areas, we don't often not that knowledgeable about it because it happens somewhere else in interventional radiology or the OR. But our patients are affected by it, and we need to know more about it.
What additional training or education do oncology nurses need to help stay current in this topic?
I definitely, as far as the devices, if you're in an infusion center and there is a request or you have a patient with an implanted pump, there's a lot of information that you need to know and seek out, because with the different pumps, they're very manufacturer specific. And it's also a skill and a process, and try to seek out a mentor to help you learn about it and then also to precept you for the first several times that you do it.
What are some additional resources maybe for patients or maybe other providers who want to learn more about this?
Well, as I mentioned before, in the Oncology Nursing Society Chemotherapy and Immunotherapy Guidelines and Recommendations for Practice, there is a large section on intra-arterial chemotherapy. Also in the previous Oncology Nursing Society Vascular Access Device Guidelines, there is a chapter on intra-arterial chemotherapy. And there are some wonderful articles that have been published by nurses in CJON, the Clinical Journal of Oncology Nursing, on these topics. There's one that was done several years ago on implanted pumps by some of my colleagues at Ohio State. And there are also some articles on hepatic chemoembolization.
Wonderful. Well, we'll be sure to include links to some of those in our episode notes today for our listeners. Thank you again, Lisa. I think we've covered a very important and a very unique topic today, and I really appreciate your time and expertise in sharing your knowledge with our listeners. Do you have any final comments to share?
No, thank you very much for this opportunity.
Great. Thank you. Thank you for listening to the Oncology Nursing Podcast. Tell us about your favorite part in this episode by leaving a review wherever you download your podcast. For more resources and information about oncology nursing, visit us at ons.org or voice.ons.org. The ideas and opinions shared in this episode represent those of the guest and not necessarily ONS.